Yes, so I guess it's worth mentioning what the format was supposed to be, as we had all imagined it, was pre-recorded talks because all of us are unfortunately attending virtually, then 3 minutes Q&A, and then we were supposed to have 15 minutes panel at the end with a roundtable. But because there's no possibility of having an interactive session, we've just devised last minute with Steve and very kindly the person at AV, this way of at least me being able to be with you today. But unfortunately, the only interactions possible will be with Steve in a room, me, and if you have any questions also, obviously post them on the app. I guess we're ready to start. As I mentioned, we have 3 talks today out of the 4 that were scheduled. The very first one is by Dr. Gwenaelle Douaud. I'm not sure I'm pronouncing her name correctly, unfortunately, who is at the University of Freiburg. And she and her colleagues from the medical center have examined the impact of COVID-19 on the central nervous system in patients at the subacute and chronic stage using FDG-PET. And so I hope that you will enjoy her talk. Thank you very much all for attending today. And sorry again for the way this is all happening haphazardly.
Dear organizers, dear ladies and gentlemen, thank you very much for a kind invitation to present at this year's symposium dedicated to brain imaging in COVID. My name is Gwenaelle Douaud, and it's my pleasure to present you the work of our multidisciplinary and multi-department team at the University of Freiburg, Germany, on neocortical dysfunction and cognitive impairment in COVID-19, the prospective FDG-PET study. The outbreak of 2019 coronavirus disease that is caused by SARS-CoV-2 virus has caused hundreds of thousands of deaths, and healthcare professionals struggle to properly manage those patients. Besides respiratory syndromes, relevant portion of inpatients develop disturbance of gust and olfaction, myalgia, encephalopathy, and other less common neurological symptoms. After noticing cognitive decline linked to COVID in few patients, prospective Freiburg near COVID registry was established with the aim to explore this disturbance of gust and olfaction, myalgia, encephalopathy. Coronavirus disease that is caused by SARS-CoV-2 virus has caused hundreds of thousands of deaths. Thank you very much for a kind invitation to present at this year's symposium dedicated to brain imaging in COVID. My name is Gwenaelle Douaud, and it's my pleasure to present you the work of our multidisciplinary and multi-department team at the University of Freiburg, Germany, on neocortical dysfunction and cognitive impairment in COVID-19, the prospective FDG-PET study. The outbreak of 2019 coronavirus disease that is caused by SARS-CoV-2 virus has caused hundreds of thousands of deaths, and healthcare professionals struggle to properly manage those patients. Besides respiratory syndromes, relevant portion of inpatients develop disturbance of gust and olfaction, myalgia, encephalopathy, and other less common neurological symptoms. After noticing cognitive decline linked to COVID in few patients, prospective Freiburg near COVID registry was established with the aim to explore this cognitive impairment. Patients with at least one new neurological symptom related to COVID-19 and PCR-confirmed SARS-CoV-2 infection were included. Exclusion criteria were premorbid neurological conditions, as for example, dementia and actual ICU treatment. Enrolled patients underwent neurological examination, cognitive test battery, CSF investigation, MRI, and FDG-PET. Out of 41 screened patients, 29 were included with the most common neurological symptom being disturbed gust and olfaction. I want to additionally emphasize that the enrolled patients were affected severely enough to require inpatient but not ICU treatment. Cognitive performance was tested with Montreal Cognitive Assessment Scale, where the score lower than 26 of 30 points indicates pathological result. Mean MoCA of this cohort was 22 points, which is at the level of the MCI to dementia. Mainly frontoparietal cortical functions were impaired as identified from the significantly lower scores in attention, executive, and memory domains in COVID-19 patients compared to controls. 13 of 29 patients underwent cerebral MRI on a 3 Tesla scanner. In 4 patients, microembolic subacute infarcts were observed. However, no other structural changes, and in particular, no signs of atrophy, acute encephalitis, or leptomeningeal enhancements were found. Region of interest-based or voxel-based analysis of dynamic susceptibility contrast perfusion did not reveal significant differences when compared with the control group. 15 of 29 patients who showed at least 2 new neurological symptoms underwent cerebral FDG PET. Visual reads of individual FDG PET scans yield abnormal results of 2/3 of patients, with predominant pathological finding being frontoparietal hypometabolism. We did not observe any other pattern clearly suggestive of neurodegenerative disease that can serve as an alternative explanation of cognitive decline in these patients. Based on earlier studies demonstrating the superior value of disease-specific spatial covariance pattern for diagnosis, prognosis, and monitoring of various disorders, we employed principal components analysis, or shortly PCA, to explore whether spatial covariance pattern also exists in COVID-19. This approach is operating on the notion that localized disease process ought to engage multiple interacting brain regions that are widely distributed over the whole brain. And opposite the conventional regional or voxel-based statistical PET analysis, PCA offers additional advantage that does not require explicit definition of the reference region for count rate normalization, which is currently unknown. So for statistical comparison with our COVID group, we selected age-matched control patients scanned under identical conditions from our database in whom somatic CNS disorders were carefully excluded. By comparison of COVID patients to control cohort, we identified the so-called COVID-19 pattern, which shows highly significant separation between the groups. Here, voxels with the negative weights, showed in cool colors, involve extensive neocortical areas with regional pronunciation in parietal and frontal association cortices, and to a less extent caudate nuclei. Voxels with positive weights, indicated here in hot colors, show the regions with preserved metabolic activity. We found no convincing evidence of regional hypermetabolism. Visual reads of individual and group average images show no regions of obvious hypermetabolism like in autoimmune or viral encephalitis. Likewise, exploratory regional analysis showed no significant difference of the lean body weight and plasma glucose adjusted standardized uptake value of FDG as a marker of regional glucose metabolism in areas with positive weights in our COVID-19 patients compared to control patients. By applying a topographic profile rating algorithm, we identified the so-called pattern expression score, the measure that reflects the degree of similarity between the identified pattern and individual subjects' data. As expected, pattern expression score of the COVID-19 pattern was significantly higher in COVID-19 patients compared to control patients and was highly significantly associated with experts' visual reads. Finally, there was a significant linear association between cognitive assessment, being MoCA global score adjusted for years of education, and pattern expression score. Higher pattern expression scores of the severity of cortical hypermetabolism was associated with worse cognitive performance. We are well aware of the problem and artifacts that may be introduced by selection of an inappropriate reference region for count rate normalization of PET data. Moreover, our patients were scanned in a fully digital PET-CT system that provides superior image quality and spatial resolution. However, given the recent advance of this technique, a normal database of healthy controls was not yet available. Therefore, the validation analysis for this study was performed in 2 steps. First, we conducted conventional group analysis using SPM and white matter as a reference region. The pattern of widespread frontoparietal dominant neocortical hypermetabolism was very similar to the results of PCA. Second, we repeated the PCA analysis using different control group, namely age-matched healthy controls from the ADNI database. The identified covariance pattern is similar to the results of our primary analysis, albeit the differences between scanners introduce some additional deviation of signal. Cognitive impairment is a frequent complaint, and as I showed, it can be related to cortical hypermetabolism at the subacute stage of disease. However, it is unclear if these changes are reversible. So to study this, we reassessed FDG-PET and also MoCA performance in 8 patients presenting for a follow-up in the chronic stage of disease, approximately 6 months after symptom onset. Compared to acute stage, we found an essential reversibility of decreased neocortical metabolism in frontoparietal and to less extent temporal neocortical regions. Of note, the present population does not represent the so-called long COVID, typically defined by long-lasting, not exclusively neurological complaints at least 4 to 12 weeks after symptom onset, since patients were enrolled into this prospective study based on new neurological symptoms at the subacute stage, and then follow up to investigate the reversibility of symptoms. In fact, 50% of patients did not have any more self-reported cognitive deficits at the time of the second examination. Correlation analysis revealed significant relationship between cognitive assessment and PET over the subacute and chronic stages. Moreover, performance in MoCA for 6 of 8 patients was still within the range of mild cognitive impairment. The expression of the COVID-19 related spatial covariance pattern at follow-up was significantly reduced compared to the subacute stage. However, in comparison to control patients, they still exhibited a slightly higher pattern expression. This, together with the residual hypermetabolism, indicated a shift toward normal levels, but not definite return in some patients. So this prospective register study highlights neocortical dysfunction as a sequel of COVID-19 by identifying cognitive decline using comprehensive neuropsychological testing with MoCA and functional imaging with FDG-PET. The visual reads of FDG-PET brain scans revealed abnormal results of 2/3 of patients with predominant frontoparietal hypermetabolism. Moreover, PCA-based analysis identified COVID-19-related spatial covariance pattern, which is characterized by negative weights in widespread neocortical areas. And the expression of this pattern is highly associated with cognitive performance and was validated by conventional voxel-wise analysis and alternative control database. In the follow-up study, we demonstrated central reversibility of decreased neocortical glucose metabolism, accompanied by an improvement of cognitive functions in COVID-19 patients from their subacute to their chronic stage after SARS-CoV-2 infection. Also, residual neocortical dysfunction is still measurable even 6 months after manifestation of disease. Significant recovery of regional neuronal function and cognition can be clearly stated. This slow but evident recovery provides fundamental and I think novel insight into the pathophysiology of cognitive deficits associated with COVID-19. I highly encourage interested audience to refer to our publications on subacute and chronic COVID stages and a comprehensive review of the FDG-PET imaging in COVID for further details. I would like to acknowledge the contribution of my colleagues from the Department of Nuclear Medicine, Neuroradiology, Internal Medicine, Neurology, and Clinical Neuroscience. And if you have any questions, comments, or inquiries, please feel free to reach out using the following email. Thank you very much for your attention.
I think we can really thank Gwenaelle for doing a very fantastic job with her talk, considering also that she knew that she would not be able to interact with you, with any of you. Please feel free to send her any questions, as you've seen her email address. But in the meantime, I think if there's no question, which I don't seem to think there are on the app, then we shall proceed to the second talk, so pre-recorded. Professor Eric Gedge really wanted to be there with you, but he had other commitments at the same time, unfortunately. So he is from the University of Aix-Marseille, and is presenting again some results of FDG PET, this time on long COVID and also in children, which is, I think, a very unique study that he's carried out. And with this, I'll leave it to Professor Gedge. Thank you very much.
Dear colleagues, you certainly know that many patients have persistence or recurrence of functional complaints after initial COVID infection. The condition may affect approximately 15% of patients after 3 months, with major impact on healthcare and social systems. The objective of this talk is to investigate the possible brain substrate of these symptoms using metabolic brain PET imaging. We have first to mention that the neurotropism of COVID-19 is now at least well described at the acute stage, with several possible neurological complications, such as stroke and encephalitis. And that beyond COVID-19, many psychiatric and neuropsychiatric complications have been reported with other coronavirus, both at the acute stage and at the later stage, with approximately 1/3 of PTSD, 15% of persistent depression and anxiety disorders, with also a possible clinical overlap with fibromyalgia and chronic fatigue syndrome. And on a historical perspective, we should also mention that psychiatric and neurological disorders were previously associated with the Spanish influenza epidemic, both in adults and in children. Importantly, the neurotropism of other coronavirus has been previously demonstrated across the lamina cribosa, from the nose to the brain, where ACE2 receptors are strongly expressed, with thereafter possible transsynaptic progression. And on this hypothesis of the transethmoidal pathway, the first cerebral node will be the olfactory bulb, which is strongly connected to other limbic and paralimbic structures, which are involved in memory and emotion processes. And this limbic system is known to be closely linked on brainstem nuclei to the autonomic nervous system, whose dysregulation can lead to cardiovascular, muscular, gastrointestinal, and respiratory symptoms. And you see the involvement of the brainstem is suspected to explain part of respiratory symptoms of patients. In this line, we first showed in June 2020 that FDG PET can identify individual brain hypometabolism within the olfactory pathway, and more largely the limbic system, the medial temporal lobe, thalamus, hypothalamus, but also the brainstem and the cerebellum. We have then conducted a larger retrospective PET study of patients with long COVID in comparison to 44 healthy subjects. You have here our inclusion and exclusion criteria. 45 consecutive adult patients with functional complaints of possible brain origin, and we kept only patients with biological confirmed cases, without brain lesion on morphological imaging, and without neurological and or psychiatric antecedents, with finally 35 patients included. The mean age of 55, 57% of women, patients who are mostly overweight, high frequency of diabetes and of high blood pressure. Paradoxically, only few patients were active smokers. An initial infection of mild to moderate severity. And at a mean evaluation of 3 months after infection, We reported 80% of dyspnea, 66% of pain syndromes, approximately 1 patient upon 2 with cognitive complaints and insomnia, and 25 to 30% approximately of patients with hyposmia or dysgeusia, and also approximately 1/3 of patients with PTSD. And we showed an increased number of functional complaints in younger patients, and also perhaps paradoxically in patients with a longer delay from the initial infections symptoms, which could suggest a clinical worsening over time. We confirm in this article this profile of brain hypometabolism involving the olfactory bulbs within the frontabasal region and the network of connected cerebral regions, including limbic and paralimbic regions, the amygdala, the hippocampus, the brainstem, pons, medulla, and also the cerebellum. This profile was highly discriminant to distinguish patients against healthy subjects. I will not have time to develop the set of correlated results, but globally, the increased number of functional complaints was associated with more severe hypometabolism. The olfactory hypometabolism was more severe in patients treated for hypertension with ACE drugs, and interestingly, less severe in patients initially treated by nasal decongestant. And finally, the brain hypometabolism was not associated with the initial severity of the infection. Our global hypothesis is developed in this article. In details, we believe that the identified pathway described the limbic network of post-Madeleine, linking olfaction to memory and emotion. This limbic system is itself closely linked to the autonomic nervous system in the brainstem, whose dysregulation can lead to cardiovascular, muscular, gastrointestinal, and respiratory symptoms. In our study, we found an association between olfactory and memory complaints. We should also note that olfactory loss has also been described as the main risk factor for subsequent memory impairment in long COVID. And on other models, for example, Alzheimer's disease, the olfactory dysfunction induces hippocampal atrophy, worsening memory decline. This line, olfactory rehabilitation, has been proposed to improve memory decline. On the whole, we believe that diastasis or differentiation from the olfactory pathway could contribute to the brain hypometabolism in most patients with long COVID, with possible interest for local decongestant and functional rehabilitation. But the diffusion of inflammation beyond olfactory pathways could occur in patients with no recovery, and further study will be needed to develop and validate, for example, intranasally administered anti-inflammatory or antiviral drugs. We noticed that this same network was the most consistent cross-etiology findings on this recent systemic review of 90 neuroimaging and neuropathological studies on COVID-19. It is also crucial to mention this very important study from the UK Bank, recently published in Nature, with a follow-up of subjects before and then after the outbreak. Our colleagues described longitudinal gray matter loss in limbic areas directly linked to the olfactory system in infected patients in comparison to controls and in link with symptoms. These findings are also coherent with the demonstration of viral persistence and inflammation associated to anosmia in human olfactory epithelium and hamster-infected brain. This paired profile of olfactory dysfunction is, however, distinct to those found in Parkinson disease. We have now described this same hypometabolic pattern in 7 children with long COVID. approximately 5 months after the infection, in comparison to 21 controls of same age with functional neurological disorders, with only partial reversibility at 6 and 12 months. The right medial 3D view is astonishingly similar between the two groups of patients, the adults and the children. This multicentric study aimed to provide a consensual description of brain hypometabolism on a visual interpretation of FDG PET imaging in patients with suspected neurological long COVID. On average, PET scans were performed at 11 months from symptom onset, and on the 143 brain FDG PET scans performed, the specific hypometabolic profile was similarly identified in the 3 nuclear medicine departments. We noticed that approximately 50% of the scan were visually interpreted as normal. And interestingly, the fact that at the individual level, approximately half of patients with symptoms had no brain metabolic abnormalities at this time demonstrate that this hypometabolic pattern is not simply a functional consequence of symptoms of functional complaints, but more probably the signature of genuine brain impairment. In this study, we use covariance analysis to compare the metabolic networks between 35 patients with long COVID and 44 healthy subjects. We identify in blue with negative weights the component corresponding to the network we previously described in hypometabolism, involving the limbic system, the brainstem, the cerebellum. This component was correlated with the number of complaints. We then performed the same analysis in 6 subjects explored at the subacute stage of COVID-19. And interestingly, the previous described network is in these patients identified with positive weights in red, with hypermetabolism that we interpret as to be an inflammation. And this transition from positive to negative weights, from hypermetabolism to hypometabolism, from the subacute to the long COVID stage, may remind other transition of metabolic patterns in other models, such as encephalitis. And to test this hypothesis, we use the same covariance method to analyze 73 patients with encephalitis occurred before the outbreak. We identify a very similar network positively correlated to those of the acute stage of COVID-19 and negatively correlated to those of long COVID, demonstrating that at least the same regions were involved in long COVID and in encephalitis-like covariance patterns, with opposite bottom-up weights from hypermetabolism to hypometabolism. To conclude this part, we believe that these new results reinforce the hypothesis of network disruption through early diffusion of inflammation, perhaps the infection, followed by hypometabolic sequelae in long COVID, with therapeutic implications for early intervention. We have also to mention the possible entanglement with psychological factors. The tricky issue could be to determine if the infection is also strongly associated with increased psychiatric disorders by neurotropism. We should indeed not exclude that the infection itself, perhaps the inflammation, may also more directly contribute to the degradation of mental health of infected people. We have tried to answer the issue of the possible impact of lockdown on this large study in patients who had a brain PET during the lockdown period in comparison to the homologous period in 2019 and the deconfinement period. We showed that the longer lockdown duration was negatively correlated to the metabolism of the sensory motor cortex, with a prevailing effect on the left dominant pyramidal tract and on younger patients, also including the left amygdala. And with only partial reversibility after 15 days of deconfinement, we conclude that restriction of physical activities and deconditioning and social isolation may lead to functional disturbances of sensory motor and emotional brain networks, but weak overlap was found with the reported pattern of hypometabolism in long COVID. It is important to mention the recommendation proposed by these authors after a systemic review. They are, in my point of view, reasonable and correspond to our own practice, namely a possible interest of PET examination in selected cases after clinical evaluation on initial issues of differential diagnosis within the framework of existing authorization and recommendation, particular for encephalitis or neurodegenerative disease, and in the context of the persistence of symptoms over several months, or in the event of worsening, to contribute to the cerebral assessment of such patients. But in my opinion, the clinical impairment is not limited to cognitive domain in these patients, and thus the indication should not be strictly limited to the neuropsychological evaluation. And I mentioned that the recommendation of the ENM Neuroimaging Committee are in preparation for this important topic. To conclude, the work has, of course, a lot of limitation, especially the design, the qualitative evaluation of complaints, functional complaints. We nevertheless show a brain PET hypometabolic profile from olfactory pathway to other limbic region and brainstem with an individual relevance linked to the functional complaints with a similar pattern for adults and children, distinct from those of functional and neurological disorders and those of the deconditioning impact of lockdown. A brain network concordant with the hypothesis previously made based on results obtained is other coronavirus, concordant with a multimodal systemic review, and concordant with the results previously recently published using MRI with this follow-up before and after the pandemics in infected patients and controls. We don't know yet, of course, the exact mechanism, directly viral, inflammatory, immune, and perhaps vascular, and we don't know also the potential reversibility. Thank you for your attention. I would like to thank all our contributors or our collaborators on this multidisciplinary work, which is still in progress. Thank you.
For those of you who have just joined us, yes, this format is really quite special. We were told, unfortunately, we will not be able to interact with any of you. So very kindly, Steve and the AV person have set up this Zoom with me so that I can be with you. I've got the very awkward privilege of introducing my own talk next. So I'm Professor Gwenaelle Douaud. I'm from the University of Oxford. And please stay with us. Steve and I mean, hopefully I will have no internet problem. We'll be able to answer all your questions afterwards. Thank you very much. Well, first of all, apologies to all of you who have come in person or are attending online. You will have seen that none of the speakers in this symposium have been able to make it in person, and we won't be able to interact with you online either. So please feel free to email any of us if you have still any questions at the end of our talks. My own presentation is on the effect associated with SARS-CoV-2 infection, which we found were associated with changes in brain structure in the UK Biobank. I'm Gwenaelle Douaud. I'm a part of the FEMEP Center, which is itself part of the bigger Wellcome Center for Integrative Neuroimaging, which is part of the University of Oxford. So I don't know how many of you will have seen already many slides on this subject. There is an increased focus on the effects of mild to moderate COVID-19 in longer term, and that's been true already when we started working on these paper and these analyses a year ago. But of course, also increased focus on brain-related pathology with neurological and cognitive deficits, for instance, gustatory impairment, hyposmia, impacts shown in radiological and postmortem analysis, and then this heavily debated presence of the coronavirus itself in the central nervous system. But back then, especially a year ago, brain imaging studies had really focused on acute cases, so hospitalized participants or patients who had been hospitalized, and radiological reports of single cases or case series based on CT, PET, and MRI scans. Brain imaging studies had also all scan participants post-infection, so just looked at a snapshot after they had been infected. And that's really where the UK Biobank imaging study can make such a big difference. So for those of you who do not know about the UK Biobank, this is a long-term prospective epidemiological study with information containing genetics, blood samples, lifestyle information, diet, etc., in over 500,000 UK participants, middle-aged and older UK participants. And the imaging data will be available in 100,000 of them. When I started giving talks on the UK Biobank, we had passed our 10,000th participant, and that was probably around 2016. And then only 3 years later, before the pandemic hit, we had passed 40,000 participants. So more than 30,000 had been scanned across the 3 different imaging centers for the UK Biobank in the meantime. Then obviously everything was stopped during the pandemic. So what was the idea here for the UK Biobank COVID-19 imaging study? Well, we had 43,000 participants for whom we had brain scans before the start of this pandemic. And so starting February 2021, hundreds of these participants were invited, so on a volunteering basis, invited back for a second scan. The whole idea here really was to investigate the longitudinal effects of SARS-CoV-2 infection by comparing the imaging scans taken from participants before and after the infection. So compare these changes, if you want, between the control group, so the non-infected participants, and those who have been infected by SARS-CoV-2. So compare the changes between the 2 scans, one taken before the start of the pandemic and one during the pandemic and after infection. The whole idea here is really that getting a baseline scan before infection can help us disentangle the contribution of the pathogenic process related to the SARS-CoV-2 infection from pre-existing differences in the brain of participants who can go on to contract COVID-19. So what did we have? We had participants for whom we validated the COVID-19 status either positive based on health records or 2 positive antibody lateral flow test, or negative based on the same criteria. And at the time when we froze the study back in June 2021, we had 401 SARS-CoV-2 participants with 2 usable scans, one before the pandemic, obviously, and one during the pandemic in 2021. But importantly, 96% of the cases had mild infection. In other words, only 15 of these 401 participants, infected participants, had been hospitalized due to COVID-19. And on average, the second scan was acquired on average 4.5 months after infection. This was matched to a control group, which was matched for age, sex, interval between the 2 scans, ethnicity, and location of the first imaging assessment. As I said, there are 3 imaging assessment locations with the UK Biobank. So we got 384 controls for these. And these controls were matched beyond this demographic data. They were matched for most of the risk factors we could think of: systolic blood pressure, diastolic blood pressure, diabetes, weight, BMI, alcohol intake, tobacco smoking, of course, socioeconomic status. But also, when we looked at the full array of all non-imaging phenotypes, more than 7,000 of them, we found no significant differences. But obviously, correcting for multiple comparisons across so many variables is quite a blunt tool. So please have a look at our paper for more in-depth and more subtle kind of analysis, corollary analysis on this. So what did we find? Well, we adopted two different approaches, one hypothesis-driven, focusing on the limbic olfactory-related regions, and one exploratory approach, which covered the entirety of the brain. And both really confirmed the involvement of these olfactory-related regions. In fact, we had 67 significant results for the exploratory approach, and half of these were in these limbic olfactory-related regions. And all of these results indicated greater tissue damage, whether by a proxy of diffusion imaging or loss of contrast between gray and white matter, and increased tissue loss, volume or thickness in SARS-CoV-2 group. And that was true, for instance, in the left parahippocampal gyrus, as you can see here on the left, but also particularly if you look at this sliding window that we took 10 years of sliding window, looking at age, when the cases, so the infected participants here in orange, are actually quite similar to the controls in their 50s, this starts really diverging quite considerably in their 70s. And that's the same whichever regions we're looking at. Left orbital frontal cortex, these diffusion indices inside the functional network of the primary olfactory regions, temporal piriform cortex, olfactory tubercle. Again, something quite similar maybe in their 50s, but these greater tissue damage and tissue atrophy is more marked really at higher ages. That was true not only in the limbic olfactory regions, but also overall when looking at the ratio of the brain to the total intracranial volume, so global shrinking of the volume of the brain, but also in other regions, such as, for instance, the cross-2 of the cerebellum, which is this very cognitive, higher order part of the cerebellum. We looked, for instance, at the cortical thickness reduction, so greater atrophy again in the SARS-CoV-2 group. And we could see in the cortical surface here, over the entire cortical surface, that indeed most of the results are located around these limbic olfactory regions, the parahippocampal gyrus, the orbital frontal cortex, but it also extends in regions such as the anterior cingulate cortex or the anterior insula and the temporal pole, the supramarginal gyrus, etc. And these results really remain significant when we excluded all of the hospitalized participants. So that was absolutely still true when looking only at the mild infection cases. When in turn we compared the hospitalized cases, only 15 of them, remember, compared with the non-hospitalized cases, we found the same pattern again in the same region, so greater atrophy in the hospitalized cases in the parahippocampal gyrus, orbital frontal cortex, anterior cingulate cortex, but it also vastly extended, as you can see here in the frontal, parietal regions and temporal areas, essentially higher order again. We then turn into looking at cognitive differences in the SARS-CoV-2 group. We focus on 10 cognitive scores, and for these, we selected these cognitive scores based on how much differences they were showing in an out-of-sample of healthy controls, or at least non-demented controls, compared with people at risk for dementia or who had dementia. And based on these 10 cognitive scores, what we found was, again, a greater cognitive decline in the SARS-CoV-2 group. So obviously there is a small cognitive decline happening in the controls as well. 3 years has passed by, but you can see that this greater cognitive decline is quite marked again in participants in their 70s here for the time to complete the numeric and alphanumeric trials of the trail-making test. and it goes even to showing a difference of an additional, if you want, time taken to complete that task of 30% for the participants, the infected participants in their 70s. Once more, the results remain the same after excluding the 15 hospitalized cases. So that was absolutely true in the mild infected participants. And in turn, we could relate the duration to complete the trial B with the greater atrophy that we found in a cross-2 of the cerebellum. So what have we found here? Well, we have really something that's quite important, which is the first longitudinal imaging study where SARS-CoV-2 positive participants were scanned before the infection. And that is really important because the pattern of the results is slightly different. If you just look at that snapshot post-infection, it tells you a slightly different story from if you look at the differential between the 2 time points across the 2 groups, of course. And so these longitudinal analyses revealed a significant deleterious impact associated with SARS-CoV-2 on the brain. And this was mainly in the olfactory cortical system. We also found an additional diffuse loss of gray matter on top of these more regional effects. And the hospitalized cases showed greater gray matter loss than the non-hospitalized cases, which is perhaps unsurprising. But I should point out this was a trend. This was not significant because the hospitalized cases, we had only 15 of them. So that was really a power issue here. And finally, we found greater cognitive decline in both processing speed and executive function, really markedly in the trail-making test for the alphanumeric test with SARS-CoV-2 infection. The clear limitation of this study are, first of all, lack of clinical severity stratification. We didn't have, apart from being able to distinguish the patients who had been hospitalized from the participants who had not been, there was no other kind of way for us to assess the severity of their clinical symptoms. And indeed, we didn't have the information about whether there were ongoing any symptoms when they were scanned 4.5 months after their initial infection. So we didn't know if they had, importantly, anosmia, or if they had, signs of long COVID, such as brain fog. We also didn't have the information on the vaccination status of these participants, but I should say that the vast majority of them had been infected before vaccination had become available in January 2021 in the UK. There was only a small number of BAM participants, which is really a bias that pre-exists already in the UK Biobank. And this data only covers the first and second wave, so the original strain of SARS-CoV-2, as well as the alpha, mainly, and beta and gamma variants. And the numbers were too small to be able to contrast the effects of the two, because really the clinical presentation tends to be a bit different between these different variants, but also now we know as well with Omicron. And finally, the MRI acquisition was the one developed for UK Biobank, so had not been optimized for the olfactory bulbs in the primary olfactory cortex. So the million-dollar question is really, why is it in the olfactory cortex? Well, some people have obviously proposed that there was neurotropism, so invasion of the virus in the brain, but there's obviously conflicting evidence at the moment, possibly depending on the degree of severity or the kind of variants. Maybe a lot of things will be resolved in the coming months or years. Could also be an anterograde degeneration starting with the olfactory neurons, so no need to actually for the virus to get into the brain itself. More and more evidence point out really neuroinflammation, the kind of effects that we see also, for instance, with influenza. And of course, it could be also at least some of these effects seen in the brain around the olfactory regions could be related to sensory deprivation due to hyposmia or anosmia or loss of gustatory sense. That really in turn brings the possibility that if this is due to, or at least some of it is due to sensory deprivation, when these senses are recovered, hopefully over time, after a few weeks, after a few months, then it might be that these differences in the brain, these abnormalities in the brain are reversible. And there are for these some small studies that point out some evidence that there is some normalization happening in the brain after 6 months. It doesn't completely resolve. Obviously, there's still some residual differences, but perhaps some normalization in a few of the patients that have been followed for that long with PET scanning. And on that cheery note, I would like to thank all of my collaborators in Oxford, in London, at the NIH, especially Sujin Lee and Steve Smith, who have put an insane amount of work into that paper and that study. Our founders, the Wellcome Trust, and thank you very much for your attention. Please feel free to send me an email if you have any questions, because unfortunately we cannot interact either in person or online here with this symposium. Thank you very much.
Great. So Gwen will be able to answer some questions live now. I think there's at least 2 that haven't been answered yet. And feel free to add any more questions on the app.
Yes. I'm just looking at them. Thank you very much. Yes, first of all, again, apologies. There was really a mix of COVID, personal circumstances, and the fact that we learned last minute that there was not budget for any interaction online either, which makes it all very non-interactive, apart from this little bit that was just our last minute. So, are there any plans to rescan UK biobank participants we run cognitive tests at the 3rd time point? Yes, we would very much. This is honestly out of our hands. We do not, preside over the decisions of the UK biobank, but we would very, very much like to see these participants come back. Obviously, quite a few of the controls we have been infected in the meantime, so that will be also interesting to see that. But we are hoping, obviously, that we'll see some, recovery, just like what was seen in pets. But obviously, this is all up in the air at the moment. So yeah, the questions about why they're 55, they're actually 51 to 81. It was just a matter of a 10-year window, sliding window. So they're 51 to 81, and that's yes, because the brain imaging started later than the original visit for the UK Biobank. How would the results look if you did a cross-sectional analysis? So very excellent question. So really that shows the difference between longitudinal and cross-sectional. All of the results are actually in the, there's so many supplementary material, but it is, we've given all of these results in the supplementary table. I can't quite remember which one, maybe 2 or 3, something like that. And you can see what the results would have looked like if we had done only cross-sectional at the 2nd time point, so mimicking what the vast majority of the brain imaging studies to date have been able to do. It does point out the same kind of, limbic, olfactory, but the emphasis is slightly different on which regions are really undergoing the most changes. And that is possibly because there's some also interaction with a slight baseline difference, which is something that you can see also that we've put in the paper. Could you explain where the olfactory cortex is located? Yes. So olfactory bulb, and then going into the primary olfactory cortex that is right above the sinuses, which is something that is notoriously difficult to image. But then in that context, what we did was to look at the functional network of the primary olfactory cortex, and in these regions we found some differences. There's also the orbitofrontal cortex, which is the secondary olfactory cortex. And the otorhinal, of course, and parietal.
It'd be good to repeat the questions. So one question here, Gwen. Did you find any sex differences, especially in the hospitalized group?
So we have not looked at this. I will not be able to tell you. There are only 15 or 14, I can't remember now. 15 cases of hospitalized participants, so I don't think that would have been quite reasonable to do a gender look at gender differences. That's a good question. I think we are really underpowered to look at this. has there been any 7 tests of long COVID? This is ongoing in our lab by Prof. Pattinson. And yes, obviously to address the yes, actually, sorry, I should maybe repeat the question. Has there been any 7 Tesla imaging of long of long COVID patients, or any plans to do so? So yes, obviously focusing on the brainstem. It's ongoing, but obviously not within the UK Biobank. Do you think? Oh, sorry. Go ahead, Steve.
Sure. So, are there any data on peripheral inflammation? Any correlation with structural changes?
Can you repeat that? The information, or just quote information?
Are there any data on peripheral inflammation and any correlation with structural changes?
So, not in the data set that, not that COVID imaging specific UK Biobank study. I think there might be some ongoing analysis of blood samples. And so, but at the moment, I don't think the data is available yet, but that would be obviously very interesting to look into this.
Did you see any similarities in the COVID effects with Alzheimer's effects?
In the location, some of it. I haven't looked at some kind of, correlation across maps. Try to see it is obviously limbic, but there is more accent over the entorhinal parahippocampal rather than there are still differences in the hippocampus and orbitofrontal and anterior insular. So it's not perfectly matching at all Alzheimer's, and obviously we'll need to see, in maybe a year or two whether these things get worse or if actually they recover, if some of it is actually due to anosmia or sensory deprivation.
How would the results look like if you did a cross-sectional analysis?
I've already answered this one.
I should have been paying attention.
You were trying to monitor at the same time. Yes, again, similar, but with a slight different emphasis. It's all in the paper, in supplementary material, supplementary table.
Do you think the hospitalized patients showed alterations because of hospitalization or more severe case of COVID?
So that's a very good question. Again, pressing the fact that only 15 of the participants had been hospitalized, and that's probably, due to the volunteering nature of how we recruited the participants. Obviously, the ones that were feeling better and not as knocked down by COVID were able to participate. We, on the other hand, carried out an ancillary analysis of the effect of pneumonia, and we saw some effect in a completely out-of-sample cohort in the UK Biobank, longitudinal, and we found some effects associated with pneumonia, but not at all with the same pattern and in the same extent that what we've seen in COVID-19. In terms of correlation of severity, we could not go, unfortunately, beyond separating hospitalized patients from those who had not been hospitalized, because we don't have any measures on either oxygenation or anosmia or any kind of symptoms, unfortunately, within this cohort.
Great. Can I do one?
Yeah.
Are the data openly available or need to be accessed through Biobank? All of the data is available from Biobank. Most of it is available from the normal core showcase variables, like the IDPs. Then for this study, we made up some custom new IDPs, which were sufficiently specialized for this study that we're not including them in the core set that we produce on behalf of Biobank, but they are returned to Biobank as a one-off returned bulk download. So all of it is available. Gwen, maybe we should make this the last question. Can you explain your finding that the thalamus differed between groups at baseline?
No. And that's not just the thalamus. Actually, what we extended was actually look also at the effect modulated by age, and that's there's a map that provided, I think, as either extended data or supplementary figure. I cannot remember, but you'll see that highlights quite nice structures in terms of gray matter volume, partial volume estimate. Oh, I've frozen.
It's okay. We heard all of that. Okay, we should probably finish.
Oh, yeah, okay. But basically, yes, but, you know, there are some very subtle differences between, at baseline between the two groups. Nothing in the risk factors. Can you still hear me?
Yeah, we can hear you.
Okay, nothing in the risk factors. And nothing in major kind of socioeconomic status and these kind of things. But there are very subtle differences. So they might be related to these subcortical differences. We'll actually be looking into this in the larger COVID-19 group now.
Great.
Yeah, that's it. Okay, thank you very much, everyone, for being patient with this. The format of this symposium, and have a great rest of your day in Glasgow. Bye.